Hello guys, and welcome back to my channel. If you're new here, then welcome. My name's Sarah, I'm a doctor in the UK and I make videos about my life as a doctor and what I get up to in my free time. If you're interested in seeing some vlogs about what I get up to at work, then head on over to my playlists and you'll find loads of videos about my life as a doctor. I'll link a few in the description box below. So today I want to talk about something that went a bit wrong the other day at work. I think we all know about this tendency on Instagram and Facebook and even YouTube of people kind of just showing a highlight reel of their lives. Of course we all do it, and I myself am guilty of it as well, but I want to try and keep things as real as possible on this channel. I always have done, and I want to show you the things that go well as the things that don't go quite so well and don't go to plan. So the other day I had a bit of a nasty shock when I realised that I had nearly missed a hip fracture and I'd nearly sent this patient home without even properly getting him the investigations that he needed. So I'm going to tell you the story of how on earth that happened. So if you don't know, I work in the emergency department, and this particular patient that I saw was an elderly gentleman. The presenting complaint that he had was a fall. So this man lived in a care home. He has a past medical history of atrial fibrillation, and that is where your heart pumps out of rhythm, and he was on a blood thinner for that. He also had a past medical history of severe dementia, so he was quite confused all the time. And the carers at the care home had brought him in because he'd had a fall out of bed. They weren't sure what time that fall had happened. They just found him on the floor in his bedroom and they wanted to bring him to the emergency department to get him checked, quite rightly so. So they said to me that since he's fallen, he kind of seems himself, but he's always a bit confused and can be a bit up and down. So they don't know if he's more confused than normal. They also said that he has been up and about walking, but he had been complaining of a little bit of pain in his left hip. So I did a full history as best as I can from the care home. They were really organised and they brought in this care package of all of the medications he's on and things like that, which is really useful. We love it in the emergency department when people are organised like that. Now, this patient had obviously fallen out of bed. They didn't know how long he'd been on the floor for, and the patient himself was quite confused, wasn't able to really tell me anything. He couldn't remember the fall. So the things that are going through my mind in the emergency department when I assess people are, is this a life-threatening emergency? And then once you've ruled that out, you then start to think about what is wrong with this patient. And we're really simple in the emergency department, and the way that we assess every single patient is via an ABCDE assessment. So A is airway, B is breathing, C is circulation, D is disability, and E is environmental factors and exposure, where you have a good look at the patient as a whole. You do your A to E assessment. That helps you with immediate management of any life-threatening things, and it sort of starts to point you towards a diagnosis and management plan. So the first things that are going through my head are, has this man got any immediate life-threatening injuries? The fact that he's on a blood thinner is something that is quite important in patients who've had a fall, because it makes you more likely to bleed substantially. So for example, if he had a bleed in the brain and he was on a blood thinner, he would be more likely to bleed more profusely, and that bleed could be more catastrophic. The second thing I was thinking about, has he got any other injuries elsewhere on his body? And the third thing I was thinking was, because this patient's been on the floor for a long time, has he got any problems related to that? Has he got rhabdomyolysis, where your muscles break down from being on the floor for such a long time and actually start to cause problems with your kidneys? Has he got any bumps, bruises or pressure sores where he's been laying on the floor for goodness knows how long? So on examination, I found him to be confused, and his carers said that they weren't sure if it was worse than normal or not. We use confusion as part of an assessment to see whether someone's got a problem with their brain, and because this gentleman already had dementia, it was difficult to say whether that confusion was associated with any sort of bleed or pathology in the brain. In order to be sure, and because of the fact he'd had an unwitnessed fall and he was on a blood thinner, I ordered a CT head for him. I did a top to toe examination, and the carers had said that they'd already seen him walking and that he was complaining of a bit of pain in the left hip. Hip fractures are a common problem. We see them a lot in the elderly, and we have quite an elderly population. Hip fractures are actually more common in patients with dementia, and that's for a couple of reasons. One is that patients with dementia are more likely to be vitamin D deficient because they don't go outside as much, and that can weaken your bones. They're also more likely to have thinner bones, less dense bones, so things like osteopenia and osteoporosis, where your bone density is lower and you're more at risk of fractures. People with dementia are also more likely to have falls because of their confusion. So all in all, that is just a recipe for hip fractures to occur. So bearing that in mind, what you'd expect to see in a patient with a hip fracture are some particular signs as you examine them. So I did a top to toe examination of this patient, and to be honest, I do that on all of the patients that I see in the emergency department, especially when they've had a fall and they're not able to clearly voice what's wrong with them like this gentleman had. So just focusing on the hip examination, because spoiler alert, as you know from the title of this video, that is what I missed. What you do when you examine a joint or any of the musculoskeletal system is pretty much the same all through the body. So you do inspection, so having a really good look, palpation, which is having a feel, and then movement. And just generally, if you're thinking that someone might have a hip fracture, the things that you'd be looking for on inspection would be any sort of bruising over the area, any opening of the skin, so if they've got an open fracture where the bone's actually ripped through the skin, any deformity, so specifically deformity over the hip joint or deformity of the leg itself. And the classic thing that we think of with a hip fracture is that the leg is shortened and externally rotated. Now this man didn't have any of those signs. The things that we look for on palpation, so on feeling the actual joint itself, is pain when you press over the joint, maybe some pain when you press into the groin or down the leg, and some people actually talk about pain in the knee. So when we're taught musculoskeletal exams, we're always taught to examine the joint above and the joint below, because sometimes you get referred pain where you've actually got an injury to one joint but the pain is appearing in the joint above or below. He had no pain whatsoever. He just sat there and let me feel. I was asking over and over again, do you have any pain? And he said something along the lines of, I'm tip top, nothing wrong here. So that kind of made me falsely reassured at that point. And then some of the things that we do to assess movement are we get patients to lay flat and ask them to lift up their leg straight. We call that a straight leg raise. And whether they're able to do that on either side helps us work out whether they've got some hip injury. And this gentleman, his left leg, he was slightly less able to do it, but again wasn't complaining of any pain. But he still was able to lift it to quite a good degree, and his right leg was normal. So at this point I was falsely reassured into thinking this man probably had some soft tissue injury to his leg, and I wasn't thinking along the lines of a fracture. My management plan for him was to get a CT head, if anything showed up on the CT head, to refer to the neurosurgeons and reverse his blood thinning agent, and do all of the things that might be associated with that. If his CT head was normal, my plan was to get a mobility assessment, which is basically where a member of the nursing staff or one of the doctors gets the patient up, watches them walk, and if they are able to weight bear normally, they can go home. Then we say that is a normal mobility assessment. And if he was able to mobilise as well as he normally could, bearing in mind that one of the carers was there and she was able to tell us whether or not he could mobilise like he would normally do in the home, then I was thinking that we'd get this gentleman back to his care home, back to his usual place of residence, get him out of the hospital where there's lots of germs and other things that could cause him problems. So, ordered the CT head, he waited for that, he had it, it came back as normal. I then said to one of the nurses, would you mind doing a mobility assessment for this gentleman, and then we'll likely get him home. And now in A&E in Nottingham we've got an area where it's out of the majors department and it's kind of a bit more comfortable for people to wait if they're awaiting transport home. So, but you have to ask permission from a consultant to get those patients into that area. So I went to my consultant and I explained the history. And I said to him, I've got this patient, got a patient who's got dementia. He came in with an unwitnessed fall. He has had a normal CT head, and he's passed his mobility assessment but complains of a little bit of pain in his left hip when he's walking. Is it all right if I send him round to the area where we get patients to wait for transport home, because I'd like to get him back to his care home? And my consultant said, no, you need to get him a hip x-ray and a pelvic x-ray. So at this point I was a bit frustrated. The department was really busy and I was thinking to myself, I've already spent a really long time with this patient. I'm sure there's nothing going to come up on this x-ray. I want to get him home. It feels unfair to him that he has to be waiting this long. But my consultant had said he had his reasoning for this and that I should get the exam. So I ordered an x-ray. Lo and behold, the x-ray popped up on my screen when it had been done, and he had an undisplaced intracapsular fracture. Now I'll show you what that means. So this is my very simple diagram of the hip joint. Here is the ball and this is the socket, which is the pelvis. You've got the femur coming down here and the two lumps that you see, that's the greater trochanter and that's the lesser trochanter. So this red line represents the intertrochanteric line. It's an imaginary line which we draw between the lesser trochanter and the greater trochanter, and any fractures that occur proximal to it, i.e. closer to the hip joint, are called intracapsular fractures, and any that occur distal to it are called extracapsular fractures. So the patient that I saw had a fracture along this breaky line that I've shown here, so it was an intracapsular fracture. Although there was a break in the bone at this point, the bone itself had stayed in the correct formation, so it was called an undisplaced fracture. When bones break and move, they become displaced fractures. So this is an example of what it would look like if the bones had actually moved out of their correct alignment. So I rang the orthopaedic surgeons immediately and asked them what they'd like to do with this patient, and they said that they wanted to keep him in, most likely do surgery on him. The reasoning behind that is that undisplaced fractures, although not too risky in themselves, can become displaced fractures quite easily. Normally with undisplaced fractures, if you're going to manage them conservatively, i.e. not really do a lot for them, just give pain relief and things like that, you'd get them to have bed rest and wait for the bone to heal. But in this case, this patient's confused. There's no way he's going to lay in bed, and he's clearly got some impaired sensation there. He's not really feeling any pain from that hip. This is not a candidate for bed rest. He won't get better if we just say he should have bed rest. So they decided to bring him in and operate, and this will give this patient a much better outcome. So after all this, I'd spoken to the orthopaedic surgeons, I'd explained to the carer and the patient what was happening, and ordered everything else that I needed to package him up and get him sent off to the orthopaedic ward. I went back to my consultant and I said to him, I showed him the x-ray and I explained what I'd done, and he sat me down and said, this is something that happens really frequently, and this is something that as a department we're trying to address. As we know, patients who have dementia or are more likely to fall, they present in an unusual way. So like with this gentleman, they don't always experience as much pain as you or I might feel if we'd broken our hip. Can't always express that pain in the same way that you or I might. So whereas we would be able to just say I'm in pain, they might actually become delirious or become agitated rather than saying I'm in pain, because their brains are impaired, they're cognitively impaired. So unwitnessed falls with dementia get hip x-rays and pelvic x-rays now, and this is a particular example where this one got picked up, and I really feel like I've learnt a lesson from this. I think it was a really interesting case for me because although we see patients with dementia day in, day out, we see hip fractures day in, day out, so none of that was particularly remarkable to me. The fact that it was a near miss was remarkable to me, and this consultant told me that he's seen many cases that have been dismissed by junior doctors like myself as no injury, and then a couple of days later that patient comes back in with a displaced fracture or extreme pain and another fall because they can't weight bear. So lesson learnt for me, and I think that there's a few things that I've learnt from this. Firstly, I learnt that clinical information. The second thing is that it really drilled into me the importance of teamwork and communicating with your team. the more senior members of the team are there to support us and to help us with our clinical decision making. And I was really grateful that that consultant took the time to actually explain that all to me, because it was a real learning point for me. And that was one of the reasons I wanted to make this video, because I think it's important to be self-aware and realise where you do have gaps in your knowledge and where you could do with doing a little bit of extra learning and reading. And for me, this was one of them. Really glad that the patient didn't come to any harm and that nothing bad actually did happen. It's made sure that I won't do something like that again, and it has kind of strengthened the idea in my head that communication and teamwork in the emergency department is really, really key. So I hope you guys have enjoyed this video. I hope you've learned something from it as well. Let me know if you enjoy these kind of videos where I talk about cases, because I like filming them, and for me it's like a personal diary. I can look back at this in a few years' time and think about how I've progressed as a doctor. I know, even looking back at videos that I made when I was in medical school or at the start of becoming a doctor, I look back and think, wow, I've changed and grown a lot since then. So for me, it's like a little personal diary as well. But obviously, it's great to be able to pass things on to you guys. If you have enjoyed it, then give me a thumbs up. It helps me know whether you're enjoying my content. Leave me a comment and let me know what brought you to this channel. Are you here because you're a medical student, a nursing student, or did you just happen to get presented this by the weird and wonderful YouTube algorithm? This week's shout out goes to No Logic OK. Very interesting username you got there. Thank you for your comment on my last video, and if you guys would like to get a shout out in my next video, then leave me a comment down below and maybe it'll be you next week. Anyway guys, I will catch you in my next video. I'll see you soon. Bye.